Welcome to the AI and Radiology lecture series. This is a collaboration between the School of Computing at Queen's University and the Department of Diagnostic Radiology here at Queen's University. This is our third set of AI lecture series, which we began in 2019, and it has been extremely successful in bringing all sorts of people interested in artificial intelligence and radiology and healthcare in general to the same room, or in this case, to the same virtual room. Thank you very much for participating. We are anticipating over 200 registrants to listen in today, and we have a wonderful speaker lined up, Dr. Anjum Ahmed from ACFA. But before I introduce him, I'd like to introduce a couple other people who you can see on your screen. First is Chloe Desroche. She's our DI coordinator who's assisting us in organizing and running this webinar. And we have Dr. Amber Simpson. Dr. Amber Simpson is my co-host, and she's going to be moderating the Q&A this week as well as next week in our second part of the AI lecture series. Briefly, I want to give you a little short bio on Dr. Simpson. So she's the Canada Research Chair in Biomedical Computing and Informatics, and she's an Associate Professor here at the School of Computing at Queen's and in the Department of Biomedical and Molecular Sciences in the Faculty of Health Sciences here at Queen's. She specializes in biomedical data science and computer-aided surgery. Her research group is focused on developing novel computational strategies for improving human health. She's an American Association of Cancer Research Award winner and the holder of multiple National Institutes of Health grants. She received her PhD in computer science from Queen's, and we are glad that she's joining us here today. So before I introduce Dr. Ahmed, Chloe, do you want to just give some brief introduction about housekeeping and how we're going to run this thing?
Yes, so really quick, the participants were on the call a little bit earlier, probably heard us chatting, but you should see a Q&A button on your screen. So you are welcome to use that to submit written questions, and there will be a question period at the end.
All right, thank you. So before further ado, I'd like to introduce our guest speaker for today, Dr. Anjum Ahmed. Dr. Anjum Ahmed is the ACFA Healthcare Global Chief Medical Health Officer, and he leads enterprise imaging and AI innovation initiatives to help healthcare organizations across the globe enable value-based care models, improve care, and maximize value with their health IT investments. Dr. Anjum speaks at thought leadership events throughout the globe regarding the intersection of technology, machine learning, and cognitive computing, its applications in healthcare, impact on population health, early disease detection, and precision health. He was recently interviewed by the Financial Times of London at the CogX event on AI in London, England, in recognition of his global experience in the field of value-based application of AI in medical imaging. And we are very pleased to have him here today to share his experience on AI and radiology. Dr. Ahmed, the floor is yours.
Thank you so much, Omar, and thank you so much for the esteemed panel. I am absolutely excited to be here and speaking to you all today. I hope you can all hear me clear, right?
Yes.
Yes.
And can you see my screen as well?
Yes.
Perfect. Thank you so much. And I hope wherever you are, all of you doing well. I'm here in Mississauga, so not very far from where you are. The topic of AI, artificial intelligence, machine learning has captivated the audience across the globe. And, you know, as part of this 2 lecture series that we have, I wanted to take the opportunity to first reflect upon the industry trends in terms of, you know, what we have learned throughout our course of experience, exposure to this industry, the digital health innovation initiatives, the industry trends, and then how all of a sudden when this COVID-19 pandemic came about, how it shaped the medical imaging and specifically the radiology domain on its path towards augmented radiology and precision health. So I'll talk about some of these concepts and also share with you what we have learned from rest of the globe, what other countries are doing, and how Canada's AI strategy is evolving, and what role radiology imaging could play. Before that, quickly, as Dr. Omar mentioned, I work with ACFA Healthcare. I'm their Chief Medical Officer, and I also lead the global initiatives around innovation and an artificial intelligence strategy. The presentation today and next week will cover mostly the general industry trends and lessons learned. So that's what I wanted to share with you. No sales or marketing pitch here. And also realizing that some of these artificial intelligence solutions are still pending Health Canada clearance. Now, what have we learned in the last 30 years? How the industry has been shaping up? When we look at the first PACS or picture archiving and communication systems, the transition is now more towards enterprise imaging. And I'll talk about what is enterprise imaging and how these concepts started evolving. In 1991, when we started witnessing the transition from film to digital imaging, that evolution brought forward the adoption of picture archiving communication systems across the globe, whether in the UK with NHS, and it even transformed further between 2005 to 2007 here in Canada. And I'm giving here an example of hospital diagnostic imaging repository systems, where the concept was, how do we bring and consolidate these disparate solutions that we had across medical imaging industry or ecosystems, multiple hospitals, independent health facilities, all performing certain imaging procedures. How do you go about bringing all those together and consolidate? So from this particular timeline, the evolution of enterprise imaging started, because as you start aggregating or bringing all the medical informatics or medical imaging data together, obviously then the question is, how can you intelligently use that data? Because the more quality data you will have cross enterprise outside your hospital, sharing that data with multiple enterprise systems, what can you start learning from those, that analytical intelligence? And I can tell you, right, when this journey started around 2008, 2009, Canadian hospitals were the first ones who were asking me, now that we are aggregating this data, how can we run some intelligence on this data on our population samples and correlate it with some of these trending disease conditions across the country and be more predictive in terms of how we deliver care? So this kept evolving. AI, artificial intelligence, machine learning came in as well. Obviously, when you have data, you want to run some intelligent analytics on the data, with cloud strategy and all these platforms moving across. But let's focus on AI. When we think about artificial intelligence, what are the possible applications of AI? And then there are several, right, ranging from whether you're doing deep learning, going towards machine learning, image analysis, also bringing social network analysis of the data that patients or consumers are going about. In the session today, I'll focus on the visualization, data analytics, and the image analytics part of these possible applications of AI. There are other areas as well, robotics, Internet of Things, and that's what we will talk about in the framework of where the industry in general is going in utilizing some of these techniques and bringing those together. The challenge is, while it may look so fancy and simple from this slide deck, but really what's happening in the background is there are more than 100 startups across the world who are working on some of these AI applications, each working and focusing on its individual either specialty, if it's mental health, pharmacy, drug discovery, looking at emergency room and surgery, applications that monitor lifestyle data, patient data and risk analytics. And then there is the medical imaging aspect of this as well, within radiology, whether it is radiology, ophthalmology, dermatology, several applications being developed, focusing on each of these niche areas. And that creates a challenge, because if we are saying in the previous slide that in Canada, we were aggregating all these multiple repositories of imaging, But all these, like last count, I think there were around more than 200 startups that are working on some of these applications. Then the question there is, if these application developers are focusing on each of their individual niche, how, and in Canada, we're talking about consolidating and bringing all that data together intelligently from a patient's perspective, how do we go about managing this? The consensus that is evolving within the academia and businesses is that to succeed in the world of AI, businesses must collaborate with academia. It cannot be that my company or another startup is working on its own on a particular algorithm because there is a science or methodology behind a particular algorithm. It has to make a meaningful sense in regards to what outcomes are you trying to improve your patient population. And that's what the shift in the industry has been with the healthcare transformation that we are witnessing. Hospitals, health authorities, ministries of health across the globe, they're moving away from this hospital-centric model more towards delivery of intelligent care and precision health. So precision health or precision medicine is not about developing individual applications or devices for each and every single population, but it's more about how can you bring patients with certain clinical conditions or diagnostic based on your diagnostic criteria within a particular cohort, and what did you learn from the outcomes of those patients or population, and then how you deliver those care. So this is kind of changing the drivers in terms of how we deliver care. New diseases, I mean, we have seen with the pandemic. How can we be more coordinated and collaborative in regards to how we deliver care? More of team play as compared to care variation that we were witnessing. So the teams are coming together in terms of optimizing how we deliver services towards the path towards precision health. Now, I'm not saying that today we have a department of precision health or precision medicine in a hospital. You never know, it could be possible. So that's where the shift has been, right? So moving away from this model towards more intelligent care delivery. But again, here comes COVID and disrupts everything. We have seen that countries, with the highest spending in GDP when it comes to healthcare and health systems, they were all challenged with the arrival of COVID. Reason? Because we were not predictively intelligent in regards to how the exposure to certain conditions. And that has actually resulted even, I would say, that challenge was taken up as an opportunity across the globe. And several health authorities, governments, and health systems, they came together to see how they can address and tackle this. I would like to put this in a timeline of events that could be categorized in 4 different areas. The initial phase, the phase where the pandemic was actually called out as pandemic, the transition, and the new normal. The challenge that was faced within the initial phases was radiology on its silo. It's not a silo because the diagnosticians were so dependent upon the role of radiology that they realized that this picture archiving PACS communication system of the past is of no significance. It is going to be an enterprise imaging strategy where you need to share and collaborate, you need to share data, you need to be accessible. And that's what happened in the initial phases because the access of lab testing, radiology was asked to play its role in terms of whether you're doing chest x-rays or chest CTs, what is the diagnostic criteria. The role of radiology kept evolving from that perspective. The transition, as I see it with the new normal, I'm not calling it post-pandemic, I'm calling it the new normal because the evolution that has taken place as a result of the use of technology, by transitioning from siloed approach to more collaborative, smart viewing or workflow automation. And already some hospitals across the globe are using some of these machined tools, not only to do pixel intelligence like learning from images, but also workflow automation that revolves around patient care, whether you're generating critical alerts, whether you're doing sharing and collaboration. And I'll talk about this in the next 2 slides, starting first with the initial phase and the pandemic, and then I'll talk about the transition and the new normal. So what happened in the initial phase of the pandemic? To diagnose with X-ray or not? And that's where we need to look at the colleges, the American College of Radiology, The Canadian Association of Radiology, what was their position? In the UK, the Royal College also issued their directives in regards to how imaging could play a role. The consensus was that viral testing remains the only specific method of diagnosis. And this slide is important because I will correlate it in the context of AI. If radiology imaging in regards to chest CTs or chest x-rays are being done is more geared towards patient follow-up, whether these are admitted patients and you want to see progression or regression of the disease. In Italy and Spain or in China, there was another concept in regards to using imaging or also, for example, lung ultrasonography they were doing, that how it could be used to triage patients with certain critical findings or if they are in adult respiratory distress. So if this is how it was going about, the question that comes is, right, is this all these AI applications that specifically came about during the phase of the pandemic, are they going to be sensitive and specific enough for these use cases or workflows? And that's where the industry is still, and that's why I mentioned in the initial phases, when it comes specifically to COVID, the applications related to medical imaging analysis for COVID are still works in progress. Still a lot of data validation is required because of the non-specificity of some of those findings. The other aspect is, right, the transition to the new normal that I spoke about. How hospitals, staff, physicians, radiologists, and departments, they came together and used some of these workflow automation tools, leveraging machines, systems automation to optimize the challenge that was being faced across. And the first example, so there are 5 use cases I'll go through, and this example is from the UK, where the need for universal access across multiple care organizations. So that even if this patient has a chest x-ray done on that care pathway, how do you ensure that if a patient has a follow-up procedure, it could be correlated, because this was a network of multiple hospitals and trusts that were coming together. And this was a short story that was covered by BBC as well in the UK, where they shared how hospitals came together and shared across those images in a very secure environment, because you also want to make sure as a healthcare organizations, if these tools that you're introducing, there are no loopholes in terms of how these systems are integrated and there are no data leaks. And that's where the system automation, triage of the work list, study by study comparison of patients that are specifically relevant to a particular disease condition. In this case, it's COVID, but it could be another condition as well. If you're looking at, if you're a health system that is focused on certain cancer care conditions or chronic disease management or a trauma center, there are ways to optimize how you deliver, because as I mentioned, the system needs to be secure. The tools for communication needs to be secure in context of the clinical domain, whether it is specialty imaging, whether it is subspecialty imaging, neuroradiology, or cancer screening, as I mentioned. It has to fall in place. And that's some of the examples that we witnessed in certain countries like in Italy, Spain, in the NHS, where in one particular instance, 450 users across the trust, they were able to securely come together, maintaining their physical distance from colleagues, working from home, and deploying these systems with a seamless experience. This is something like we are doing today, right? We're talking through the Zoom presentation. And the idea is that to enable radiology to come out of their individual department or the practices and be able to be more collaborative with the care delivery. And this is something that we saw that because, as I mentioned, there were certain AI applications popping up as well. So the question was, is it possible to even integrate some of these AI generated reports into the workflow? And that is something that was possible because that saves time. And that also allows to be very specific in regards to the terminology, that's because with new diseases comes new terminology. And to be able to immediately and quickly adopt by using some of these machine learning tools, whether it is an NLP engine, natural language processing, that allows flexibility in generating certain preliminary reports, and also allows you as a health system to triage some of these reports based on those critical findings. And that's where we saw, and we are still witnessing more and more hospitals are asking similar questions in terms of how can we ensure fast reporting, remote or at home access or premise. Without naming the solution, but I've seen that certain countries, there are huge backlogs when it comes to reporting certain types of medical procedures. I'll take an example of, for example, chest x-rays. 40% of diagnostic imaging that is done across the globe is chest x-ray imaging. If you're able to automate some of those x-rays and are able to triage those x-rays at the top of your list, imagine how much time savings and efficiencies you could gain, even when we think about the reports availability and results for certain use cases. The idea with this is to optimize manual tasks. And that's another concept beyond the identification of pixels, like in a chest x-ray where you identify an abnormality. Workflow automation and triage takes it to a different level. The idea is that you are able to capture information. Let's say there are certain hospitals, what they did was they created Q&A type of service for their patients so that the receptionists are able to capture valuable information. And they're then able to evaluate if even before a particular order or image is created, in terms of what risk criteria this particular patient falls. And you're able to then to track. So the idea is that you're providing the data to the system correlates this information with, let's say out of 100 patients that are performing an X-ray today, you've got 40 or 50 patients who are specific to COVID. The idea is then you could allocate those specific cases more specifically to certain tasks, certain users, certain group of radiologists, or even if you are a referral center, you could create case management and case distribution workflows. So I wanted to take this as don't look at AI or machine learning as purely looking at pixel data when it comes to imaging. It is much more than that, and this is where it is being used in terms of machine automation, workflow automation, and task optimization. Because if you want to improve outcomes, you need to understand what tasks you're optimizing. If you do not have the definition of output you're improving, then yes, AI is working. AI is a black box that sits somewhere in the server room in the IT departments. But if you're not able to leverage that metadata, how good is that outcome? And that's where the concept around augmented intelligence is appearing now. Because AI is not AI anymore, not artificial intelligence. We said, right, we want to move towards path of precision health, delivering personalized care. So that's where augmented intelligence comes in, because you are now bringing not only the image analytics, you're bringing the maybe data from electronic medical records, data from the questionnaires that you may have created to capture patient-specific information or their health-specific information, and you're moving towards being more predictive because you want to catch signs early. These analytical dashboards can do real-time monitoring. They could allow your department to better understand and reorganize your capacity at times of need. We have also seen some hospitals in Italy, what they did was they integrated these analytical dashboards with Google Maps, and it allowed them to identify clusters of infection area in the population so that they could better manage the delivery of care, better manage remote services, so that that's where it came about in improving some of the efficiency associated with the delivery of care. The question that comes is, right, if artificial is artificial, what is augmented intelligence? The way I would like to define augmented intelligence is that it is the intersection of machine learning and advanced algorithms or applications where clinical knowledge and medical data converge on a single platform. The potential benefit of augmented intelligence are only realized if it is in context of the workflows the way I was mentioning previously. If you do not have your problem area defined, if you do not have a definition of what tasks you're optimizing, then AI will tend to simply replicate human intelligence. Whereas augmented intelligence works with and amplifies human intelligence, because that's the goal we want to achieve. AI, machine learning alone, it cannot do. It has to follow a certain path where you're able to enable not only the consolidation of imaging health records, the workflow optimization, as I spoke about in the last 5 use cases, the real-time collaboration. And that's where machine learning and automation can help you enable some of these smart use cases and workflows. The question then is, right, when we speak about augmented intelligence or AI, what use cases to consider? And that's the key question that comes from every direction. Hey, where do we begin with AI? The question comes from hospitals, the question comes from health authorities, the question comes from ministries of health, that there is so much going on in the world of AI. So what I usually answer this question is by looking at what are the colleges of radiology in the US, what is the Association of Radiology in Canada and RCR talking about. And if you look at it, it is really a good mix of use cases that have been defined. The American College of Radiology has listed around, I think 21 use cases focusing on around abdominal imaging, breast imaging, all the way from musculoskeletal neurology to thoracic. And more recently in March, they added the COVID use case as well as part of the use cases. If you look at the thought leadership coming from the Canadian Association of Radiologists, they have an interesting dynamic the way they're looking at how AI could improve radiomics, which is quantification of tumor phenotype and decision support, workflow optimization, QA, quality assurance, grading, NLP, natural language processing. And the Royal College of Radiologists in the UK, they also talk about it in terms of associating these with oncology, patient pathways, quality assurance, governance, and regulation. Because the ethical part of this is very relevant, that who takes the ownership of the decision on the use of these AI applications. And that's where the regulatory bodies are very focused in terms of how they approve these AI algorithms for clinical use, how much data was used in terms of quantifying these algorithms. And really, if you look at these artificial intelligence strategies across the globe, Canada was one of the first countries in 2017 that announced an artificial intelligence strategy. If I compare it with some of the countries where AI is gaining traction and momentum, you'd see that no two strategies are alike. Just the way I showed you in the previous slide, the thought leadership coming from the colleges. So how do you go about implementing them? Because some are focused on scientific research, talent development, public and private sector adoption. In the UK, for instance, NHS is released funding to hospitals to begin adopting AI, so that funding is not a roadblock in regards to application. Other areas, specifically, as I mentioned, was ethics in regards to the use, and also the role of the patient, right? Because in the end, we want to deliver intelligent and evidence-based care to our patient population, and how the data is being used in regards to the data and the digital infrastructure that we are developing. So this is the key in regards to what we have seen across the globe. While no two strategies are different, are similar, how can we in Canada go about implementing this, and what specific areas? There was a white paper that came out from Canadian Association of Radiologists that identified certain areas where the Canadian government should be looking at investing in radiology specifically to improve patient care for Canadians. And there were certain areas that were identified where there was, tuberculosis, which we feel is a kind of a challenge that was associated with other countries. But when I read this white paper, and one of the first projects when I was working on AI in 2016, it was actually related to chest imaging. And when I read about it, someone from health systems in Canada, they read my white paper on AI on tuberculosis. They approached, and that's when I discovered that Canada in rural community also has a challenge of early detection of tuberculosis as well. And you know, there was another requirement around clinical decision support, right? That if AI is producing certain results, how do you improve clinical decision support? How do you ensure that it is in the right clinical context and the use cases? So what use cases that need to be identified? So what are the top opportunities in Canada's healthcare systems where, when we think about investing in or focusing in regards to these digital innovations? As I mentioned, the first and the foremost answer is, what quality care area are you trying to improve? Are you trying to reduce your backlog? Are you a health system that is focused on cancer care? So what type of cancer care application do you need in a holistic way? Either it is radiology, oncology, pathology, because pathology is also a component that is going through a digital transformation. How do you enable a comprehensive patient imaging record? In Canada, we are doing a good job with the example I gave you, with the diagnostic imaging repositories that we have created. In certain other countries, the hospital systems are still in their own silos. There may be a health system with 15 or 20 hospitals in that system, but those 15 or 20 hospital health systems are not talking to another hospital system, which may have another 15 or 20 hospitals. So from that perspective, anytime, anywhere access from a medical imaging perspective has been created in Canada, especially in the province of Ontario, where we have done a good job of doing that, which means the infrastructure in Canada, in Ontario province, is very good to enable the next phase of our transformation in using these imaging analytics and use cases. And that's where multi-specialty care collaboration comes in. Because as I mentioned, what we have done in radiology and transformation to digital imaging 20 years ago, pathology is the new domain that is now moving towards digital transformation. And those who know radiology, you know, the days of DICOM, which is the digital imaging communication methodology, pathology has no standards like DICOM. So which means all proprietary data. And that's where it begins to make sense, right? How do we bring all these tools together in a secure and scalable modular platform so that you can allow the integration of innovations in AI? Because as I said, there are over 200 applications being, application developers working on AI applications across the globe. Do you have the infrastructure that enables those innovation and integration? You cannot be running behind each and every individual AI developer for your hospital. If one application developer is working, let's say, on a cancer detection algorithm for screening of lung cancers, you will find that there are 12 different companies that are working on developing a lung nodule detection algorithm. So how do you decide which innovation that you need to focus on? I'll go into more detail on this particular topic in the next lecture, next week. But really what the question that everybody then asks is, right, is AI going to replace radiologists or a physician? I think the answer to this is quite simple. The industry has come to a realization, all that hype with AI that started 5-6 years ago, that AI is not here to replace radiologists. AI actually needs radiologists. The reason being, I'll give you one prime example. The discussions are centered now around how AI or machine learning or all this workflow automation that we're talking about can help address this particular challenge that radiology has, the burnout challenge. How can we take away the manual tasks and all these activities that radiology department, radiologists or technologists, that they have to manually perform and improve and bring about automation so that radiologists, clinicians, physicians can focus on their key deliverable, which is delivery of clinical care, improving health of our population, because that's where we want to be. And that's what we're seeing, the rise of augmented radiology, that radiologists are moving from limited engagement to being more highly engaged and empowered. Instead of being inaccessible, or the days where radiology used to be in the basement in a hospital, convenient 24/7 access, not being transactional anymore. They are becoming more care team managed, accessible anytime, anywhere. And the focus being right, instead of physician centered, more patient focused, so that you are more socially connected and you are looking at not a patient that is sick, but you are actually a consultant that is providing input to the care delivery pathway for the overall health and well-being of your patient. And that's what we are seeing in some of the early adopters of AI technology. If you implement it in the right way with outcomes-based approach, that's where you start seeing the results of what were the key performance indicators that you had established before the implementation of new technology, and after the implementation of this technology, how did you go about improving this workflow? So what are we looking at when it comes to digital health revolution? The data points are increasing. I mean, the digital revolution, the next one is genomic revolution. It's countries, in Europe, even in the US, in certain states, they have started aggregating genomic data for their patient population. So imagine all this data that is being captured, not only from the health information systems or your electronic medical records. There is imaging, as I said. Imaging is becoming more and more advanced. The medical devices, the MRIs or the CT scans or functional imaging that is taking place. Then there is another evolving field, the Diagnostics. It's all generating so much data. How can we go about ensuring that while we are detecting diseases and diagnosing, we are able to be more preventive in terms of how we predict certain clinical conditions on the path towards augmented intelligence? Because imagine if you have AI or machine learning algorithm working and detecting a certain clinical condition, and you are able to aggregate information from your intelligently in the context of this particular patient, from patient's clinical history, from patient's social history, if this patient had a history of other cancers. Because radiologists, when they look at a particular image or a request comes to them, they may not know what else is going on with this patient if they find a suspected mass or lesion. Usually what they have to do is they have to either look at the requisition, the request, if there was clinical information. But how about if you're able to intelligently aggregate data from electronic medical records, from lab information systems, and are able to chart this particular patient here and indicate that, hey, Mr. Radiologist or Mr. Radiologist, this particular patient has these specific clinical, other clinical findings. So it may be a metastatic cancer going on, because that's what you want to know, if this is a related clinical condition, or where does this patient fall on the population cohort or sample? Does this patient look like similar other patients who had similar findings? And that's where you are able to learn from their the particular findings in regards to whether this patient had cancer, whether this patient had multiple findings, whether this patient has abnormal medical reports. And that's where the discussions around embedding these AI applications into your operating ecosystem. Radiologists work in their PACS environment. So you should be able to embed some of these AI, machine learning, automation tools into their workflow so that they are more empowered. The idea is that you establish some of these smart protocols for automation, enable collaboration, so that even if a radiologist is working remotely, and we will see more and more of that, the mobility aspect is coming into play as well. How do you ensure that, double reads in certain use cases, you may require second opinions or double reads. So some hospitals who are testing AI at the moment, they're seeing that if AI could be their virtual assistant, that if AI could, help them align with some of those use cases with AI generated reports and the data aggregation perspective that I spoke about. As I mentioned, in this particular session, I wanted to introduce some of these general concepts around what we are seeing, the application of AI, machine learning in radiology imaging, and what is the significance of non-imaging data in the context of empowering our physicians and radiologists with meaningful information. In the next lecture, what I would like to focus on is going to be around how, if you recall this, the second slide that I showed you with hundreds of applications that are being developed, how do you ensure that you bring them in a meaningful way into your IT systems strategy, kind of a modular platform strategy. Then the focus around converged multi-specialty. As I mentioned, if it's not just about radiology imaging, but there are other aspects of clinical records for a particular patient that reside in electronic medical records and lab information systems. So how do we intelligently automate those workflows? For example, if a chest or let's say CT head algorithm detects an intracranial hemorrhage, how good is that detection if that information still resides in that black box server on that platform somewhere in the IT room? If there is no workflow automation, meaning if the AI algorithm was able to detect an intracranial hemorrhage in a CT scan, there should be initiation of certain automated tasks. For example, maybe an alert or notification to the physician responsible for that patient, so that this particular exam can be managed then and there while the patient is still in the hospital, instead of waiting for someone else to later come and report that particular case. And that's where I'll talk about then clinical packages. Of those dozen algorithm developers, for example, I mentioned that may be focusing on lung nodule, how do you create functional clinical packages so that they are more meaningful from a clinical perspective and not only be used for your clinical care delivery, but for your research and academic purposes as well, for peer learning and further enhancement, because you want to learn from those outcomes. And that's where I talk about the evidence-based application of AI into the entire enterprise imaging domain and the framework. That was a summary of the presentation from today, and also in preparation of our presentation next week. I will I again want to thank everyone who has joined from your valuable time. It means a lot to me, and obviously want this to be also a collaborative discussion around what your thoughts may be. If you have any questions, happy to answer those questions. Thank you so much.
Thank you very much. So we have some questions. Omar, did you want to start the questions off, or do you want me to start?
I'm okay either way. Go ahead, Amber. It's up to you.
Okay, I think we can all see the Q&A section. So we have Mohammed asking, artificial augmented assisted intelligence, what shall we consider when it's mentioned as AI in the literature?
In the literature, it will still be artificial intelligence because, as I said, even when you read precision health, for example, right? As we said, there is no precision health or precision medicine department in a hospital. Artificial intelligence is the umbrella framework of what I would say some of the applications of AI, which I spoke about in the first slide, so that I can pull this up again. So these are the possible applications, as I mentioned, right, of AI. So artificial intelligence encompasses deep learning, machine learning. It is an evolving concept. Some call it adaptive intelligence, some call it assisted intelligence, augmented intelligence. The framework around augmented intelligence is gaining more traction, but in the literature, obviously, it's still artificial intelligence.
Thank you. And we have a question. In one of the early slides, you mentioned large-scale PACS. Can you elaborate as to how large is large-scale? How will it be used in today's context?
Yes, so I mentioned when large-scale PACS systems have evolved from being focused on an individual hospital or department towards being more enterprise, and that's where the concept around enterprise imaging comes in. So what is enterprise imaging? Enterprise imaging is a strategy with a modular approach where you have addressed the archiving part of the PACS, so PACS, right? Picture archiving and communication systems. So PACS includes an archive. Over the last few years, ever since that consolidation happened, health systems realized that PACS, radiology PACS cannot sit on its own silo. It needs to communicate and collaborate with other specialties, whether it is oncology, whether it is digital pathology, because when it comes to delivery of multidisciplinary care, that's how you need to open up. So that's where small systems or PACS that is able to have, being able to ingest 100,000, 300,000 annual exams has moved now towards expansion towards millions of exams that we are already seeing here in Canada with diagnostic imaging repositories. And this is being in the UK as well. And other regions and countries are actually looking at Canada. How did you go about implementing all these large scale PAC solutions? So when I said large scale, I meant beyond one hospital, beyond the boundaries of your city to another city, and these imaging repositories that we have in Canada.
Have you thought about a Google for PACS?
You never know, it might happen.
You could imagine it, right? Like you're similar to when you're on Amazon and you're looking up a product and it says, oh, you might also like this product. You could imagine where you're looking at some rare cancer and it says, oh, you had another case like this, 6 years ago, and this is the patient and this is what happened to them.
Here is your answer. So
Yeah.
The industry and some hospitals in the US specifically, they have actually started transitioning by transferring the archive portion of their PACS to the cloud. That is happening already.
Oh, yeah. Can you also comment on the role of structured reporting in radiology?
This is an excellent question because I would be covering this topic in the presentation next week. The challenge in radiology is, as compared to cardiology, cardiology has come to a consensus when it comes to structured reporting. In radiology, every other solution provider uses one methodology or other in terms of how you extract that data and how you present that data. So something that we have done is what we call sectional reports, where you're able to extract the metadata from AI findings. Let's say if you have an AI algorithm that looks at nodules, lung nodules, and if this AI algorithm is able to quantify those nodules with volumetric measurements, so what we could do is we could compare if this patient has a previous scan. So we extract those volume measurements. So we could show volume doubling time. We could show, how this particular nodule has evolved. So the kind of a lesion management, lesion tracking workflow with lung RADS kind of a workflow or BI-RADS when it comes to breast imaging. So this is how I see AI could be leveraged in bringing the metadata out of its black box server that sits somewhere and presenting it into more of what I call it as a preliminary report. So it makes it easier for radiologists, one-click sign off. If you agree, yes. If you do not agree, these are like macros, right? You could have drop downs, select which one, and go ahead. So I think radiology is going to be much more advanced in terms of reporting the way we report today.
Do you have any sense of whether the Ontario health teams will mandate that kind of thing, given the big digital health push that they want to do as part of that?
Yes, I think the first and the foremost, right? What are the focus clinical areas that we have in front of us? And if either the government of Ontario or the provincial health authorities, then we have the Cancer Care Ontario, then we have the radiology bodies. If there is a consensus around, what are the top 5 use cases? I keep giving example of NHS because I've been involved in a lot of these initial projects over there. What they did over there was they identified, let's say, top 5 chronic diseases and top 5 cancer conditions that you need to focus on. You define the workflows around those top 5 areas for each of those individual challenges. And then you were able to define, right, what KPIs do you want to measure? And how do you improve the outcomes around, early disease detection? Unnecessary procedures, you may have heard, right? Some of the biopsies and procedures that are done turn out to be false negatives or false positives. So why do we need to perform some of these procedures that are not indicated and we can avoid? It saves time for the patient, anxiety. I think that's where I think before we go even to structured reporting around this framework, the framework around what are we trying to do, what specific use cases we need to focus, and what outcomes we will improve, you will see the funding will trickle in then.
So another question from the chat is related to the specific areas in healthcare in Canada that we should focus on when it comes to AI. I think you talked about that in your talk. Is there anything else that you want to mention about that?
I absolutely, I think that's what I just commented as well, right? Giving the NHS example was identification of those 5 specific areas. I gave an example earlier in the slide regarding the tuberculosis challenge. 5-6 years ago, I wasn't aware Canada has a tuberculosis challenge. It was only a white paper that I wrote about some work I was doing on AI for a particular government in Middle East. They asked us to develop an algorithm for chest X-ray screening, and it had a tuberculosis detection element in there as well. So someone from Canada approached me, says, hey, you know, how can we use this here in Canada? I said, like, I never knew Canada had a tuberculosis screening challenge. And then I realized in certain provinces, in the rural communities and in the Northern Territories, there is actually funding available. There was actually funding available by the government of Canada for the next 5 years to invest and improve early detection. So I think that's where, as I was saying, top 5 health challenges when it comes to cancer diagnostics or other chronic diseases, and how do we go about using technology. As long as you bring that practical approach to use of technology, I think the funding is there. We need to keep asking.
So some more questions here. So here's an interesting one. Who will own the training data sets? Private companies, PACS companies, health ministries, hospitals, equipment manufacturers, or open source?
Yep. That's
or patients.
So here is the perspective of what I heard earlier this year. That was my last travel when I was in the UK in March at a conference where Royal College of Radiologists, there was a meeting. They were talking about this particular topic, who owns the data and what is the role of the patient if there is no patient consent. So their position was during the discussions that when it comes to developing AI, if you're an academic institute and you're developing AI algorithms on your own data sets and you want to improve your care delivery, you are fine as long as you are not commercializing those applications. But if you are using this data to generate revenue and you have no patient consent, that's a problem. Now, in certain other geographies and domains, and that's why you will see that some of these AI startups that are doing their work, they are using data from several other countries, which have, from a geographic reasons as well, some significance for them because of the countries they're focusing on with multi-ethnic data sets. So what they do is they develop these algorithms based on the data, and they force certain alliances with hospitals, that hospitals, if they're giving them certain data, they get certain benefits of the first use of the AI application. So it all depends on the IP revenue sharing model or the privileges that the hospital may want to have for the algorithm that was developed on their data sets. In Canada, I think our health systems are pretty clear about, in terms of the Canadian data, not leaving Canada. So whatever needs to be done stays in Canada with where you're putting up the infrastructure. So from that perspective, as I said, it is different in different geographies, how these AI algorithms are developed. But the colleges of radiology and the Canadian Association of Radiology, as I mentioned, they also have a position paper on this.
How safe is AI when we talk about data collection and patient information sharing around the world or a particular region? So I think that piggybacks on your last comment really well.
Yes, it does, because as I said, it's not just about data collection. It is also about the experience of the partner you're working with. If so, regulatory bodies, Health Canada, FDA, they have certain requirements before they clear an algorithm for clinical use. And some of those requirements are quite stringent in regards to, their ISO certifications, for example, their quality systems in place with these companies that are developing these algorithms. And I can tell you, I've been in discussions with certain AI startups since 5-6 years, and they have still not received their regulatory clearances. And that's why you'd see in Canada, I think when it comes to radiology imaging, there are not many algorithms that have been cleared by Health Canada yet when it comes to the use. So that's one perspective, the regulatory aspect. The other perspective of this is, how did you use that data, right? Okay, you got that QMS, health systems, ISO certified and everything. Which partner are you working with? What protocols are you following in your hospital? Who is the provider of the data? And the company that uses the data, how are they making sure and ensuring that anonymization is being followed properly? So that's where I would say you need to look at asking the right questions with whoever you partner with, what security, quality assurance systems they have in place, and how they safeguard your data so that when it leaves your premises, it remains anonymized, and also it is not used in any other context just for what the purpose it was used for.
Yeah, and that's really difficult to enforce because it's very easy now to pre-train a neural network off of a bunch of data, right? And then the neural network is just a series of numbers. So then why can't I just take that data? So if I'm Google, I can just take that data and use that elsewhere because it's not really the data, right? It's the network. And I don't really think we're thinking about that sufficiently. So we're just telling people that they can't do that, but we don't really have a way to enforce it in any meaningful way.
I absolutely agree with you. And there is another aspect as well. How would a radiologist know that AI is not working? Because what we are used to is, oh, wow, this algorithm has 99% sensitivity. This algorithm has 84% specificity, or the AUC is 0.95. Wow, you can start using it. But how do I know as a user that if this algorithm failed, or if it, as a human as well, right? You may need a second opinion with your colleague when you look at a particular mass or a finding. You may want to ask someone. Because we have trained these algorithms on these data sets, so how can we expect that these algorithms are also going to not have challenges in identifying certain findings? And who are they going to ask? And how would we know as a user that it's not giving me the right information? That it is not an abnormal.
So we have a question actually from email. Who takes responsibility for the AI, both in terms of negative and positive consequences? I mean, isn't it still, it's still the case that it's a radiologist, right? It's still the clinician. You need somebody to sue at the end of the day. You need somebody to ensure.
Because there's a reason also, and that's why, as I said, regulatory bodies and FDA, Health Canada, they're very clear about their position. They are not letting AI algorithms like spit out a diagnosis. What they're saying is that it is providing you enough information that this particular exam looks similar to these findings. Now you as a clinical user, because this has been flagged and triaged for you, so the benefit for you is that instead of going through a list of 1,000 x-rays, you now know at the beginning of your day, out of those 1,000 x-rays today, these are the hundreds that have been flagged as critical. So you could start your day on identifying the critical ones first.
Excellent. Omar, I think I'll pass it back to you to wrap up. We're just about out of time. Thank you so much. These were great questions, and I look forward to the next session.
Thank you so much. It's my honor. Thank you.
Thank you, Dr. Ahmed, and thank you, Dr. Simpson, for moderating and helping ask and answer a lot of those questions. Thank you, everyone, to all the participants who joined us today. I hope it was quite intellectually positive experience, and hope you learned a few things, and we'll take this back and join us next week. I believe Chloe will put up the poster for next week. Next week we have a twin bill. We have Dr. Ahmed coming back for a follow-up talk on the practical application of AI and the value of enterprise imaging. And we also have another wonderful guest speaker, Dr. Kolak from the University of Toronto at St. Mike's Hospital. And he's a radiologist. He's going to be giving a talk on the prerequisites for the intelligent use of AI in medical imaging. as opposed to the non-intelligent use. So that'll be very interesting to hear both of those talks. It will be at 5 o'clock Eastern time next Wednesday. Hope everyone can register and join us for that. Thank you again, everyone, for participating, and have a good evening.
Thank you so much.